The following podcast is part of a certified educational activity titled Targeted Treatments for Transthyretin Amyloidosis, Essential Insights for Neurologists. Access the entire activity and complete the post-test at peerview.com/TDM860. Downloadable slides and practice aids are also available.
Hello, my name is Sammy Kella. I'm a professor of neurology at Penn Presbyterian Medical Center at the University of Pennsylvania in Philadelphia. Welcome to this educational activity on the diagnosis and management of transthyretin amyloid polyneuropathy. Our goals for today are to recognize the patterns of the neuropathic symptoms and signs that raise suspicion for ATTR, and to understand the differences among currently available treatments for ATTR, and to learn how to integrate them into individualized treatment regimens for patients with ATTR polyneuropathy. Decoding ATTR variant polyneuropathy, insights into its epidemiology, pathophysiology, and disease burdens. So what is transthyretin? TTR, or transthyretin, is a protein that's primarily synthesized in the liver. It's also made in the choroid plexus, where it's secreted into the CSF, and it's the primary transport protein for thyroxine, as well as retinol. It's also made in small amounts elsewhere in the body. In the serum, it serves as the primary transport protein for vitamin A, as I said, or retinol, via the retinol binding protein, and is a minor carrier for thyroxine. It was previously known as thyroxine binding prealbumin. TTR is a sensitive indicator of malnutrition and illness, as it disappears at a rate of about 50% per day from the circulation. Low TTR levels are associated with many chronic diseases, including Alzheimer's disease, heart failure, stroke, and rheumatoid arthritis, among others. The pathogenesis of TTR is as follows. It's primarily made in the liver and secreted into the circulation as a monomer. That monomer is most stable in its tetrameric form. So this is a homotetramer that is stable when it binds thyroxine and retinol. However, when there's an amino acid misplaced in the monomer, the tetramer is unstable, and the monomers then aggregate after they have misfolded and deposit in the tissues as amyloid fibrils. While they deposit in many tissues of the body, the most symptomatic ones are the heart, the peripheral nervous system, and the gastrointestinal tract. There's also a wild-type ATTR, where there is no variant amino acid in the sequence. However, the TTR continues to misfold and deposit, again, primarily in the heart. These are abbreviated as ATTR-WT and ATTR-V for the hereditary or the variant form. There are more than 130 pathogenic variants, and they have many different phenotypes, which is what makes this difficult to diagnose as a condition. The terminology is changing. First of all, you may see the terminology with reference to the DNA sequence. For example, the V122I this is the DNA sequence, and you may see that same designation as the protein designation, where it's P142I. And you will see this throughout the presentation and throughout the literature as well. Additionally, the older terminology is been changed to reflect more the wild-type formulation rather than senile amyloid is now called wild-type. And familial amyloid cardiomyopathy and familial amyloid peripheral neuropathy are really better addressed as hereditary rather than familial. The reason is that many patients don't have a family history. And so to broaden our thinking when confronted with a patient, it is best to consider the disease as a hereditary rather than a familial disorder. Finally, there's amyloid light chain cardiomyopathy and peripheral neuropathy, and this is a different type of amyloidosis associated with a malignant clone. The genotype-phenotype correlations in ATTR, as shown on the screen here, to your right are the genotypes that are predominantly cardiac in phenotype, and to your left, the variants that are predominantly neurologic. And you can see in the middle of the screen some of the same variants that are either neurologic or cardiac predominantly can also be a mixed phenotype. So as I said, this is a condition that has many faces. The natural history of ATTR is obviously a long one because the fibrils that are misfolded are being deposited from birth. However, symptoms do not, for the most part, present until later in life. And again, they can present as a polyneuropathy, as a cardiomyopathy, or some combination of the two, ultimately leading to death from the disease. The clinical manifestations of ATTR are myriad. This busy-looking slide here gives you an idea that ATTR can present both in the peripheral nervous system as a small fiber neuropathy, a large fiber neuropathy. It can present with postural hypotension, for example. It can also have a CNS component, which is less common, but certainly needs to be recognized. And of course, the gastrointestinal symptoms, which are really quite severe in some of the variants, but not in all of them, and can be the presentation in a patient. Of course, the cardiomyopathy, either presenting as a heart failure with preserved ejection fraction, or atrial fibrillation, or some other arrhythmia, such as a conduction block, for example. In the musculoskeletal sphere, patients can have bilateral carpal tunnel syndrome, and that can present many years before the presentation of the peripheral neuropathy, the GI symptoms, or the other symptoms. Biceps tendon rupture is a particular feature of wild-type amyloidosis. Spinal stenosis can occur in wild-type and hereditary, but obviously this is a very common condition that the neurologist will confront. Of course, amyloid can be found in many tissues, as I said, and the orthopedist may see this in patients presenting with shoulder, knee, or hip pain. It can present as a myopathy, an ophthalmopathy, and rarely present with kidney or having the kidney involved as part of the clinical course of the disease. Now, the time course of development of symptoms, again, will vary. And the 5 years preceding the initial diagnosis can be some very common symptoms that may not necessarily lead one to think of amyloid, such as nausea and vomiting, a progressive peripheral neuropathy that may begin as a sensory neuropathy, then progress to a sensory motor neuropathy. But I think the main feature and the important take-home message for the neurologist is that this is a progressive neuropathy. constipation alternating with diarrhea, and you can see weight loss as well as incontinence. On the right-hand side is the cardiac manifestations, and these, of course, can include dyspnea, and that's an important and common one as a manifestation of congestive heart failure, or the ventricular hypertrophy that develops, causing the restrictive cardiomyopathy in these patients. Other systems can also be involved, as you can see in the middle of your screen, including diabetes, renal failure, carpal tunnel syndrome, and vitreous opacities, which I've not previously mentioned. Now, the genetic and the clinical characteristics of TTR variants are to some extent ethnically and racially or nationally limited. In particular, the V122I is an important one in the United States. This is a variant that has a genetic frequency in the general population of around 3.5 to 4%, with a penetrance that may be on the order of 37% or so. And while this is primarily a cardiac phenotype, as you can see in the top line of this screen, it does about 20% of patients will have a neurologic phenotype and can have peripheral neuropathy and may not have a cardiomyopathy or may not have a symptomatic cardiomyopathy. Again, this is primarily occurs in African Americans or Afro-Caribbean patients, but it is also present worldwide. The V30M patients can have an early onset or a late onset V30M. An early onset meaning patients in their 30s or 40s, and very often these will present in Portuguese, Japanese, Brazilian patients, as well as Swedes. And this is a peripheral neuropathy presentation primarily. And the late onset patients in their 50s, 60s, again, this is a worldwide presentation, but these patients, when they present later on with this variant, will have a cardiomyopathy predominant. But again, in any of these cases, you may see a mixed phenotype. This schema here will show you, again, using the old nomenclature of V122I or T60 or V30M throughout the world. And you can see in the United States, V122I or T60 as the most common, whereas in Europe and Japan, as well as Brazil, the V30M and the T60 is primarily the Irish presentation. Now, we have actually looked at this sex differences, and it turns out that women are as likely as men to develop pathogenic TTR variants. In contrast to wild-type disease, and wild-type disease tends to be a cardiomyopathy predominantly of older men, much more than it is of women, for reasons that are yet to be defined. Now, some ATTR variants are not rare in the United States, and that is the V122I, and I would like to stress this variant because, of course, the disparity in care that African Americans get. And so we should be in particular wary of a patient who is African American, who presents with a peripheral neuropathy, and we need to make sure that we have taken a history of hospitalizations or a prior history of heart failure in these patients. That combination should raise the possibility that this patient may have hereditary amyloidosis. And this data comes from large epidemiologic cohorts, as you can see listed here. the claims data for those patients with V122I found that about 89% of these patients will have lower extremity numbness, as well as a large percentage, 67, will have spinal stenosis, as well as a prior history of carpal tunnel syndrome. So things to keep in mind when seeing a patient, an African American patient, either a man or a woman, who have a peripheral neuropathy as a neurologic presentation. So again, to raise suspicion for this disease, these are the red flag symptoms, and they may not all be present at any time. But again, I urge you as clinicians to keep an eye on a patient with a progressive neuropathy, and the autonomic symptoms and dysfunction can include erectile dysfunction in younger men. Certainly, postural hypotension is a feature of the T60 patients or the V30 patients, not so much again for the V122I patients. Also, alternating diarrhea and constipation or nausea and early satiety should be a red flag. The prior history of carpal tunnel syndrome should be, especially if it's bilateral, and especially if it is recurrent, again, should be a red flag, particularly in patients who have also family history of carpal tunnel syndrome. Now, patients who have a peripheral neuropathy may have or have a history of cardiac disease manifesting as either a new onset atrial fibrillation, for example. Additionally, symptoms of heart failure and heart failure with hypertrophic cardiomyopathy when there is no prior history of hypertension or other risk factors for developing a hypertrophic cardiomyopathy should be a consideration. Patients with rotator cuff or biceps tendon rupture, again, should raise the possibility of amyloidosis, especially a biceps tendon rupture in a patient who has a history of heart failure. Vitreous opacities and periorbital hemorrhages are another important consideration, and maybe a manifesting, an early manifestation of the disease. Renal failure is often seen in patients with light chain disease, and when it is present in patients who have a hereditary or wild type variant, those patients, it's often due to cardiorenal syndrome rather than primary renal involvement. Gastrointestinal symptoms causing early satiety and unintentional weight loss and or diarrhea should again be an important feature of red flag consideration. Also, the peripheral neuropathy, while it may begin with small fiber symptoms, again, I urge you to look for weakness, because weakness, of course, is an important feature of amyloid polyneuropathy. And the weakness in particular has a pattern that is not common in other neuropathies. This is the proximal muscle weakness that occurs in a patient who does not have a clear-cut myopathy. And in those patients, the differential diagnosis often is CIDP, or chronic inflammatory demyelinating polyneuropathy, as because those patients, along with amyloid patients, are really the few neuropathies that cause proximal as well as distal weakness in a particular patient. Now, of course, having a family history of amyloidosis is definitely a red flag, as well as a prior history of a rapidly progressive neuropathy of unknown cause resulting in death, in sudden cardiac death, or in a cardiac arrhythmia in a family member should raise consideration of amyloid in the patient who is in front of you. And then in a patient who has been diagnosed, as I said, with CIDP, who does not have clear-cut demyelinating features on EMG, or may have a mixed demyelinating and axonal neuropathy by EMG or by nerve biopsy, should be considered to have amyloid, especially if they're not responding to IVIG. And typically, we give about 3 months of IVIG therapy to decide that a patient is actually responding or not responding to IVIG or other immunosuppressive treatment if they are thought to have CIDP. So for that patient, a revisiting of the diagnosis, perhaps repeat EMG or other considerations should be undertaken in that patient. So the neuropathy, and I've alluded to this, becomes particularly problematic in patients who have comorbid diabetes. And in those patients, diabetic patients or patients who have alcohol use disorder and a progressive neuropathy should raise the possibility of amyloidosis. It is known and widely accepted that patients who have even very poorly controlled diabetes do not typically develop significant weakness. They may have significant distal weakness in the lower extremities. They do not have proximal weakness unless they have had acute proximal radiculofemoral neuropathy, but that is a monophasic illness that's often associated with pain, whereas amyloid neuropathy is typically painless. So if you have a diabetic or an alcoholic patient who's developing significant proximal weakness, who does not have demonstrable myopathy from alcohol or a proximal diabetic neuropathy, should be considered for the diagnosis of amyloidosis. Again, I mentioned CIDP. Motor neuron disease, or ALS, really should not be confused with amyloid neuropathy. Motor neuron disease or multifocal motor neuropathy typically does not have the sensory component that patients with amyloidosis have, and so should not have significant confusion because of those symptoms. And on examination, patients with ALS, of course, will have upper motor neuron symptoms and signs more than symptoms, while patients with amyloid neuropathy do not have upper motor neuron findings as a part of that process. Small fiber neuropathy may be an early feature of amyloid neuropathy, but unlike small fiber neuropathy due to other conditions or idiopathic small fiber neuropathy, this is a amyloid neuropathy presenting with small fiber disease will progress, whereas idiopathic small fiber neuropathy will not progress to involve the large fibers, whereas amyloidosis, undiagnosed and untreated, will surely progress to involve large fiber modalities, as well as the motor component that's often seen in amyloidosis. I mentioned carpal tunnel syndrome bilaterally, and this is, again, a condition that can predate the presentation of the peripheral neuropathy or the cardiomyopathy. And of course, bilateral carpal tunnel syndrome is commonly seen as an occupational hazard, as an idiopathic phenomenon, or as part of a diabetic neuropathy as well. Now, patients, of course, with a peripheral neuropathy and malignancy and unexpected weight loss, malignancy or other autoimmune diseases should be in the differential diagnosis. Now, ATTR polyneuropathy will progress much more rapidly than diabetic neuropathy or CMT, as I just mentioned. And this is demonstrated by data presented in this slide, where the neuropathy impairment score, which is the score that has been used in the clinical trials, and basically this is a quantification of the score that of the clinical examination that we perform in the office, and you can see that these patients will progress as time goes on. So to enhance recognition and the diagnosis and monitoring of progression of ATTR will be the remainder of our talk, as well as the key considerations here, of course, are to check for family history, to assess for comorbidities, and especially for heart failure and for bilateral carpal tunnel, and whether the patient has had a progressive neuropathy. And I think for a patient like that, who has a progressive neuropathy with any of these comorbidities, or even without these comorbidities, genetic testing should be at the forethought of the clinician. And we can just either check for TTR variants alone, or do a more comprehensive neuropathy panel. If the TTR variant genetic testing is negative, then this is not hereditary amyloidosis. But if the patient still has amyloidosis by Congo red staining of any tissue, then consideration for either wild type or certainly for AL amyloid should be the next step. And so, again, to continue with the key considerations, if the patient has a TTR variant, one, of course, needs to assess for multiple risk factors, especially if there's a family history. And if the patient is under 40 years of age, ATTR variant is less likely to be the cause of the neuropathy. However, as I said, the patients with the V30M variant should be considered to have amyloid, and that age alone does not exclude the possibility of amyloidosis. Once a diagnosis of variant by genotype is made, tissue confirmation is needed, and any tissue can serve to provide evidence that the patient has amyloid deposition in tissues, especially if they have a neuropathy. And those patients should then have the Congo red staining material further analyzed to type the protein. And so if the protein is typed by immunohistochemistry or ideally by mass spectroscopy, then that patient has a confirmed diagnosis of amyloidosis. If the patient, the tissue and the phenotype is not convincing for symptomatic disease, and the patient has negative tissue biopsy, then the patient can be considered a carrier of the disease. But in addition to tissue diagnosis, non-invasively, TTR amyloidosis can be confirmed by cardiac scintigraphy or pyrophosphate scanning in the United States, and PYP, as the abbreviation is made, grade 3 positive scan with an elevated NT-proBNP in the absence of light chain disease. So before you get the cardiac scintigraphy, you should send the patient for kappa lambda quantitation and serum protein electrophoresis with immunofixation to exclude the possibility that this patient has light chain disease, and then go ahead and do the amyloid scintigraphy with PYP scanning. And if that is positive, that is enough of a confirmation that tissue is not needed, and the patient is now confirmed to have a diagnosis of amyloidosis and will require treatment at that point. Of course, a patient who is considered a carrier should be followed on an annual basis or a semi-annual basis, depending on the particular individual and depending on the family history of presentation. Some families will present in their 50s or in their 60s, and so consideration should be given for when a patient's family member, if that is part of the presentation, should be taken into account. AL amyloidosis will look the same on the imaging, the PYP scan, which may be falsely positive. It may also be falsely negative. And so a monoclonal protein screen is mandatory for any patient who's considered to have amyloidosis. And those patients, of course, may only have a protein elevation without having amyloidosis, the disease, and those patients are carried as monoclonal gammopathy of unknown significance or a smoldering myeloma, and they are treated with chemotherapeutic drugs, as mentioned in the slide here on the left in the purple, while the patients who have the variant TTR, which originates in the liver, can be easily misdiagnosed as having a diabetic polyneuropathy or CIDP, and those patients can be treated and should be treated with a suppressor therapy, as we will discuss in a minute, and they are listed here as eplontersen, patisiran, or vutrisiran, and they need to be seen by a neurologist to ascertain that the neuropathy is due to amyloid, whereas the patients with amyloid light chain disease, especially when they have heart failure, this is considered a medical emergency and really should be seen urgently by an oncologist. And by urgently, we mean within a week or even less, if that's possible. And so the diagnosis of AL amyloidosis, again, those patients will have a restrictive cardiomyopathy, and they may have a negative PYP scan, but typically macroglossia is much more a feature of AL amyloid than it is of TTR or even wild type. While it is known, and we have several cases in our cohort at Penn who have TTR and macroglossia, the more common feature of macroglossia is associated with AL amyloidosis. Of course, a patient with unexplained peripheral neuropathy and proteinuria or hepatomegaly or acquired factor X deficiency resulting in a coagulopathy should be considered to have AL as in the differential diagnosis. Again, evidence of amyloid in the tissue deposits is important to distinguish patients who have smoldering myeloma or MGUS. And again, that tissue needs to be stained with Congo red, and again, it needs immunohistochemistry or mass spectroscopy. And if you have a patient with serum light chain and positive immunofixation or kappa lambda quantitation, and those, at least at our facility, have to be ordered separately, and you can identify the monoclonal protein, that becomes evidence of a plasma cell dyscrasia, and that patient needs to be seen urgently. Will probably need a bone marrow biopsy to assess for the plasma cell burden and exclude multiple myeloma or a lymphoma or other B-cell lymphoproliferative disorders. Now, the recommended assessment and tools for staging or monitoring neurologic symptoms in patients with ATTR, the class 1 recommendations are, of course, the neurologic examination or the neuropathy impairment scale, which is what we do as neurologists. EMG testing for sure to determine that the patient has an axonal neuropathy. However, this may be negative in patients who have a small fiber neuropathy. And then the peripheral neuropathy disability, or the FAP staging, and the RODS questionnaire or skin biopsy are all part of the Class 1 recommendation. Class 2 recommendations for following patients and assessing patients are the orthostatic hypotension and blood pressure, which typically is low in these patients, but not necessarily, and the Compass 31 questionnaire quality of life measure. The Class 2B recommendations are autonomic reflex screening, the Norfolk quality of life diabetic neuropathy questionnaire. This questionnaire has been validated for patients with amyloid neuropathy, and so it can be used, as well as the QST. Now, again, the recommendations for staging or monitoring non-neurologic symptoms, and this is why while the neurologist can certainly monitor for some of these symptoms, this is why this is a multidisciplinary disease that requires the cooperation of hematologists, cardiologists, nephrologists, with the neurologists as well. And so the BNP and NT-proBNP, and this is something that at least in the screening can be done by the neurologist, but should be certainly followed by the cardiologist. Troponin, prealbumin, echocardiography, and TTE. The scintigraphy is used as initial evaluation. It's not really typically used for follow-up. However, that is the purview of the cardiologist. Cardiac MRI, similarly, and of course, the EGFR protein deposition. Here is the classic imaging. On the right-hand side is the pyrophosphate scan, and you can see that the heart, which is in the anterior view all the way to the right in panel B, the heart, when it has amyloid, is avid for the pyrophosphate compared to the chest wall, which is compared on the left, and that's how this scan is graded by the degree of uptake in the myocardium. And on the left is the Congo red stain on a tissue biopsy, and this is from one of our patients, and you can see the Congo red stain in the H&E on the top, and then of course under the polarizer you can see the in this case both a combination of sort of an orange on the top of at 11 o'clock and the top of the vessel, and a little bit of apple green by refringence down at the bottom, yellow arrow. And you can see under fluorescence microscopy the tissues will stain a bright red as shown. It's always helpful to have a concrete case, and Connor is a patient with a 1-year history of diarrhea and weight loss with progressive numbness and burning in the hands, and then those symptoms have also spread to the feet, and so this is a common presentation for a peripheral neuropathy for a neurologist. And so what would be the diagnostic considerations? And I would say in the broadest possible terms, one should consider a peripheral neuropathy as an overarching diagnosis before becoming more specific. And then to proceed further with the history, this patient turns out to have had a 5-year history of type 2 diabetes with poor adherence to metformin monotherapy. The diarrhea was attributed to metformin, although he stopped taking that a year ago. And the nerve conduction testing showed a fiber length dependent axonal sensory motor polyneuropathy. The A1C was 9.8. The patient had a monoclonal gammopathy excluded. However, the pyrophosphate scan was positive, And this is highly specific as well as 98% sensitive. There's one or two phenotypes that don't light up on the pyrophosphate scanning. Genetic testing identified the patient to have a V30M variant. And so this patient needs to be treated. And what follows will be the treatment approaches here. So the amyloid neuropathy treatment is both disease-directed and symptom-directed as well. For disease direction, there's TTR silencing, which is now FDA approved, and this has been shown to slow and in very early presentations may reverse the disease. And the drugs that are available are eplontersen, patisiran, and vutrisiran. You notice I didn't say inotersen, which is in the slide. However, inotersen is no longer manufactured. Tafamidis, acoramidis, and diflunisal are not FDA approved for therapy in the United States. There is no evidence to date that carpal tunnel syndrome or spinal stenosis are really affected by these drugs. And vitamin A supplementation is required. It is, however, not a known side effects, which we will talk about. The ophthalmic complications are not a known side effect. The symptom management is both for the sensory neuropathy when it is painful. Of course, pregabalin, gabapentin, duloxetine, and the tricyclics all help with the pain of the neuropathy. They don't help with the numbness per se. The tricyclics may cause or be associated with worsening orthostatic hypotension, and gabapentin can may be relatively contraindicated in patients who have significant peripheral edema because it can cause peripheral edema as well. The autonomic dysfunction, of course, managing the orthostatic hypotension is preeminent in some of these patients, as that can be quite a disabling feature. And pyridostigmine, as you can see listed here, is effective in mild symptoms. However, patients who have really significant symptoms will need midodrine, fludroxycortisone, or droxidopa. But however, there is a recombinant hypertension as a complication of these drugs, and they may not be well tolerated in patients who have significant heart failure. Not listed here, and we will mention it later, are the GI symptoms. Mechanisms of action for the silencing drugs are either small interfering RNA all the way on the left-hand side of the screen, or the antisense oligonucleotide in the middle of your screen, and CRISPR-Cas9 therapy all the way to the right. And these are designed to lower the amount of TTR by causing either degradation of mRNA, resulting in decreased translation, or suppression of the protein synthesis with CRISPR. Again, the pathogenic process is to target the liver, and the eplontersen and vutrisiran are the drugs that have now been designed to be targets that target the liver directly rather than being processed throughout all of the tissues, because of the way the ligand that has been attached to these drugs will target the hepatocytes. Again, they suppress the formation of TTR, whereas the tafamidis, acoramidis, and diflunisal stabilize the tetramer and keep the stoichiometry of the reaction to the left, where the tetramer remains stable, rather than shifting it to the right, where the disease will progress because of the deposition of the misfolded oligomers. Now, there are under investigation amyloid fibril degraders and antibodies that are directed against the amyloid fibril to try to remove them from the cells once they have been deposited. Currently, these trials are ongoing with unpublished results to date. The outcomes of the TTR polyneuropathy trials, the primary outcomes were the modified neuropathy impairment scale +7. The +7 is an indication of the additional tests for autonomic function. They also use the, which I mentioned previously, the Norfolk Quality of Life Diabetic Neuropathy Scale, and the modified BMI, which is just modified for the nutritional status, which using albumin as part of the calculation. These have resulted in clinically meaningful improvements. And you can see here what clinically meaning improvement means. It means a drop of 4 points on the neuropathy impairment scale, a drop of 12 to 4 points, anywhere in that range, for the Norfolk Quality of Life, and weight gain all the way for the MBMI, and obviously the reverse direction for the clinically meaningful deterioration. Now, the Apollo design, this was the pivotal trial for patisiran, and this is the small RNA interfering drug. This is a phase 3 RCT that looked at neuropathy impairment +7 as a primary endpoint, MBMI as a secondary endpoint, as well as the quality of life, the Norfolk Quality of Life. This was an adult trial, mostly throughout the world, but 21% was in North America. These are patients who had both TTR variants. On average, had a diagnosis made 1.4 years prior to disease entry into the trial. 43% of them had the V30M, and 0.9% of them had the V122I. They had the neuropathy impairment scale, could be anywhere from 5 to 130. The polyneuropathy disability was less than 3B for most patients. It had 225 patients in the trial. It was a 2-to-1 randomized with placebo, with patisiran. And the results were amazing. The neuropathy impairment scale on the left, the Norfolk Quality of Life on the right. The top line is a placebo arm, and you can see that over 18 months, patients deteriorated significantly in the placebo arm, whereas they may have improved to some extent in the patisiran-treated arm, both by clinical examination as well as by the Norfolk Quality of Life. So a dramatic improvement compared to placebo on all endpoints, primary and secondary. These drugs are safe. There were infusion-related reactions, and you can see here as well the deaths that were not that occurred were not attributed to the drug. And again, the Apollo trial in the open label extension at 5 years maintained both improvement and quality of life. More importantly, or most importantly, is the switch from placebo. And you can see the trajectory of the placebo patients on the left and on the right, and the top line would have been straight up, whereas once they were placebo patients switched to patisiran, their neuropathy stabilized, the quality of life stabilized. However, they did not reach the neuropathy impairment score that the patients had when they were treated initially. And so this is a plea for early diagnosis and early treatment in these patients, because time is of the essence. And once the axons are lost, they are not recoverable. The HELIOS-A trial was a trial to see whether vutrisiran, which is a subcutaneous every 3 months injection given by a healthcare professional, was effective. And the trial was performed against a historical placebo from the Apollo trial. It was felt not to be ethical to have an FDA-approved drug available to patients and to deny them and give them placebo. And so patients, however, were randomized in addition to vutrisiran to patisiran to demonstrate efficacy of vutrisiran to be comparable to that of patisiran. And those patients, again, as in adult patients, the same demographics essentially as the original trial. And again, the results in the primary and the secondary endpoints were as good as the pivotal trials, demonstrating that there's a significant placebo, significant stabilization of the neuropathy compared to placebo, both by the neuropathy impairment score +7, as well as Norfolk quality of life. The HELIOS primary and secondary endpoints is as stratified from baseline neuropathy severity. And you can see that, again, for the vutrisiran, these patients, compared to historical external placebo, did really quite well and statistically significant measures. And so the safety of the vutrisiran is really also quite good. There were no serious adverse events resulting in death. There were a few serious adverse events as listed here. However, they were not thought to be due to the medications. And so the NEURO-TTRansform trial design for eplontersen, similarly to the vutrisiran trial, the NEURO-TTR historical placebo was used. Again, patients were randomized in this trial 6-to-1 arm, with patients receiving eplontersen, again randomized to inotersen, a small number, 24 versus 144 in the eplontersen. And after 35 weeks, the inotersen patients switched over to eplontersen. The final analysis was made at 66 weeks, and then there was an open label extension for up to 3 years. Again, this was an adult trial, and the patients were comparable in terms of the both the severity of the neuropathy to the historical placebo patients. And again, the eplontersen trial at week 66 showed clear improvement, or I should say stabilization of the neuropathy, both by the NMNIS and the Norfolk compared to the historical placebo. And again, the secondary endpoints were reached on all measures in terms of disability and in walking, and those patients remained relatively stable throughout their treatment course. And the autonomic symptoms, while they have improved to some degree in these trials, there continues to be some worsening of some of these symptoms, as demonstrated in this slide. The safety drugs of the eplontersen remains quite good. Again, there were no deaths attributable to the drug in the trial. Their thrombocytopenia and glomerulonephritis, which had been features of inotersen, were not clinically meaningful in patients receiving eplontersen in this trial, and none of these side effects led to discontinuation of the drug. Again, vitamin A deficiency is listed here as an adverse event, but this is a known and expected side effect of the drug, and so is not, as I said, did not show evidence of clinically meaningful ophthalmic deterioration during the trial or in the open label extension. Now, individualizing current targeted treatments for ATTR variant polyneuropathy. Do you need to supplement for these patients and those who have a cardiomyopathy, neuropathy indication, and what are the common side effects? So for eplontersen, this is a subcutaneous injection that's given once a month via an auto-injector. You do need to supplement with vitamin A. There's an FDA fast track for cardiomyopathy, but it's not available at this time. Neuropathy indication, this is indicated for polyneuropathy deemed to be due to amyloidosis. And again, the most common side effect is reduction in vitamin A and perhaps vomiting. Patisiran is given by IV injection every 3 weeks. You do need pre-medication. You do need to supplement with vitamin A. It is not indicated for cardiomyopathy. It is indicated for patients with a peripheral neuropathy. URIs and infusion-related reactions are the most common. Vutrisiran is given by sub-Q injection every 3 months. It has to be performed either at an infusion clinic or by a healthcare provider. No pre-medication is needed. Vitamin A needs to be supplemented. Cardiomyopathy is an indication in this with this drug, and neuropathy, of course, is the indication. Pain in the extremities and arthralgias are side effects, as well as a reduction in vitamin A. Now, is combination therapy better than monotherapy? This is from our center. It was a retrospective cohort study of 119 patients who had symptoms. And so these patients did not have a safety signal. And I think that is the most important conclusion of our observation in this cohort. More about the management of GI amyloidosis as promised. This same diarrhea is one of the most, if not the most important symptom that patients have. And it restricts them from going out to restaurants. It restricts them from eating the foods they like. It is socially disabling, and it can be quite severe in some variants. And there are some dietary modifications that may be helpful, including smaller meals in the evening, longer interval between the evening meal and lying down, calorie supplements for patients who have malnutrition, and for cramping and diarrhea, the FODMAP diet may be helpful. Medications such as antiemetics and so on may be helpful for the nausea. For the diarrhea, at our center, there's little hesitancy to use a tincture of opium or other opioid receptor agonists for these patients. Of course, loperamide or other antidiarrheals may be helpful. Antibiotics may be useful as well, and this is where a gastroenterologist may be helpful to help manage the diarrhea. The constipation can be problematic as well, and laxatives as well as dietary variants may be helpful. And so, for patients with polyneuropathy, of course, the neuropathic pain can be a very disabling component. And in addition to the gabapentin and pregabalin, I find that oxcarbazepine is particularly useful for patients with a lancinating neuropathy pain. The diarrhea and constipation we just mentioned. Appetite stimulants may be needed. Erectile dysfunction, probably best managed by a urologist. Orthostatic hypotension can be managed in the usual way with the usual drugs, in addition to droxidopa. Gastroparesis, again, nausea and vomiting. All of these GI symptoms should be managed by a specialist. Dry eyes should be seen and managed by the ophthalmologist. Oculoleptomeningeal symptoms can be uncommon, but they should be a consideration in a patient with, particularly in a patient with amyloid, who may develop subarachnoid hemorrhages and other complications of CNS amyloidosis. So revisiting Connor, who is now 61 years old, had a history of diarrhea for a year, weight loss, progressive numbness, and burning in the hands and feet, and was found to have the V30M and a polyneuropathy, a sensory motor polyneuropathy. Also had poorly controlled diabetes, type 2 with A1C of 9.8. What are your recommendations for targeted treatment and symptom management of the ATTR targeted therapy, diarrhea, and uncontrolled type 2 diabetes? And this is where you need a constellation of healthcare providers, as well as rehab medicine, and of course, unfortunately, the palliative care team for patients who have advanced cardiomyopathy. And cardiomyopathy tends to be the cause of death in the majority of these patients, except, of course, for the patients with the V30M early variant who don't have a cardiomyopathy. And the peripheral neuropathy or the inanition may be the cause of death in those patients. The milestones in the management are very exciting, and you can see 2023 and 2024, 2025, the last several years have been pivotal. However, this slide is also helpful because we've been using now patisiran, had used inotersen and diflunisal for a long time now, and these drugs have proven safe. So even though there were no safety signals in the open label extension, by virtue of real world use, and there is published data to support this, these drugs remained effective and safe to be used in patients. So the takeaways are ATTR genotypes may vary. They vary in their phenotypes, the age of onset, and V122I is pretty common in the United States. This is a multi-organ disease. You need to have a high index of suspicion to avoid failing to diagnose this disease. The targeted treatments, when initiated promptly, can certainly slow the progression of the polyneuropathy. They certainly slow and improve the quality of life of these patients. Physicians, neurologists are really very well positioned to begin a patient's journey in treatment and to improve the disparities in healthcare that are prevalent in our society. Transthyretin amyloidosis remains an area of intense research. And I will tell you that there are many projects that are ongoing, and the future remains very exciting for this disease. That ends our discussion for today. I hope you found this activity informative and useful to your practice, and I thank you for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca and Ionis Pharmaceuticals. To access all materials for this activity, visit peerview.com/TDM860.